Hello, and welcome to this special edition of a Health Podyssey. I'm your host, Alan Weil, and today we're doing something new. We're recording our podcast live as part of Health Affairs Policy Spotlight event series. This series features wide-ranging conversations with influential health policy experts in Washington, D.C. and beyond. My guest today is Meena Seshamani, Deputy Administrator and Director of the Center for Medicare at CMS. Dr. Seshamani was my guest on a policy spotlight last year, but given how much Medicare-related news there is these days, we thought it was good to have you back. And there's a lot to talk about: Medicare Advantage, prescription drug prices, the value-based care agenda, and I'm sure we'll cover more. Now, before coming to CMS, Dr. Seshamani was Vice President of Clinical Care Transformation at MedStar Health and an Assistant Professor at MedStar Georgetown University Hospital. She has her BA from Brown University, an MD from the University of Pennsylvania School of Medicine, PhD in Health Economics from the University of Oxford, where she was a Marshall Scholar. So both an economist and I always get this wrong, otolaryngology surgeon, the best I can do as a non-clinician. She's practiced at Kaiser Permanente in San Francisco, served as Director of the Office of Health Reform at the U.S. Department of Health and Human Services. Now, I will say, because we're doing both a podcast and a policy spotlight, if you are in our live audience, you can submit questions using the Q&A button at the bottom of the screen. I will do my best to weave them into the conversation. It's helpful if they are short and of general interest. And if you get them to me before the closing bell, an hour from now, so I have time to ask them. With those preliminaries, Dr. Seshamani, it's so great to have you back for another policy spotlight, and welcome also to a Health Podyssey.
It's great to be back. Thanks for having me, Alan.
So, Meena, you and I have worked together enough. I hope I can call you Meena.
Yes.
When you came on before, you were talking about your agenda, and here we are, deep into it. Just to provide a little structure to our conversation, tell me what you view as your top priorities, and we'll start working through some of them, and I'll dig a little deeper as we go.
Yeah, absolutely. Well, Alan, building off of our last conversation, Medicare really plays a critical role in driving change in our healthcare system. Right? As the largest payer, almost $1 trillion in claims, partnering with 1 million clinicians, 6,000 hospitals. So, really our agenda has been how we can leverage Medicare and utilize the Medicare program to really drive change, not only for the 64 million people who rely on the Medicare program, but also what, path that sets for the broader system. Thinking about how we can advance health equity such that everyone has a fair and just opportunity to obtain their optimal health, regardless of the various characteristics that come into play in influencing someone's health or their ability to access healthcare. How we can expand access to coverage and care, driving innovation for high quality, whole person care, and being good stewards of the Medicare program. And you mentioned, in your intro, kind of 3 big areas in which we are driving change: Medicare Advantage, implementation of the new prescription drug law, the Inflation Reduction Act, and all the work we're doing in transforming care through our value-based care initiatives, and also through our, underlying traditional Medicare program as well. So I'm sure we can dive into any and all of that.
Well, let's do exactly that. So I think it's good to take them in the order that you mentioned. I guess I kicked it off that way. Medicare Advantage, it's half the program now. And I don't think even its biggest boosters at the time, and of course they're precursors to MA, but I don't think we ever thought we'd get to this point. And so it becomes important in its own right. And just as you said that Medicare is a tool, an opportunity to affect the entire healthcare system, the play between MA and traditional Medicare also there's a mutually reinforcing and as well as sort of a competitive element to them. So why don't we start, if you could just tell me what's top of your mind on MA, and then I'll probably ask you a few questions about the items on my mind.
Yeah, absolutely. And, piggybacking off of what you said, Alan, Medicare Advantage plays a very important role in the Medicare program, right? When I think about the Medicare program, there is Medicare Part A and B for traditional fee-for-service Medicare. There's Part C, Medicare Advantage, Part D, prescription drug coverage, and then the Medigap and supplemental policies. And, my goal is to make sure that we have a robust set of options that are all geared towards serving the person with Medicare, driving the kind of vision, the collective vision that we all have. And so to that end, last year, we put out a request for information in the Medicare Advantage program. The first time that we put out there and said, hey, we want to discuss what's working, what isn't, and really engaging everybody who's involved in this space. So health plans, providers, patient groups, employers, academics, and we got more than 4,000 comments from that request for information. And those comments and that feedback that we got really has formed the foundation of some of the policymaking that we've been doing. Again, driving towards those pillars. So, for example, where we now have for health equity, have created a health equity index in the Medicare Advantage program under the star ratings, so that health plans that are caring for underserved populations, if they meet the quality metrics, they can be eligible for additional reward, in line with what we're doing elsewhere in fee-for-service as well, so that we can reward excellent care for underserved populations. We heard a lot about the confusion that's been created with potentially misleading marketing practices. That's something that we heard from absolutely every single, group out there. And so we proposed and finalized policies to rein in misleading marketing practices, saying you can't use the Medicare logo in a misleading way. You have to say which health plans you are representing, and other, policies like that. We also heard from many different groups about prior authorization, where plans wanted to have clearer rules of the road of what kinds of utilization management they can do. Providers commented on the incredible burden that some of the prior authorization was creating, and patients expressed that they felt they couldn't get access to medically necessary care. So we also put out policies saying, look, the prior authorizations must follow traditional Medicare national coverage decisions or local coverage decisions. Where there isn't one, then you have to follow publicly available, widespread clinical evidence and have, regular yearly updates and review of the clinical protocols, again, to try to make sure that all of what's happening in Medicare Advantage is really serving the people that we intend to serve. So those are just, a few examples from our rule. And then, we heard a lot about payments and the importance of payment accuracy. So in the latest rate announcement, we had finalized to update the data years from using 2014 to 2019 in the risk adjustment model, to update the diagnostic nomenclature to move from ICD-9 to ICD-10, and then also to take a look at what the coding patterns are between Medicare Advantage and fee-for-service to really utilize those codes that are associated with incremental costs of treatment so that payments can be more accurate. And those are changes to the risk adjustment model that are getting phased in, over the next 3 years. Again, and that really comes to how do we improve equity? How do we improve quality? How do we make sure people have good choices so they can get the care they need? And how do we make sure we're being good stewards of the program?
So I really like that the agenda is driven by an RFI, and you mentioned things like prior authorization and marketing, which don't tend to be what fill the pages of Health Affairs. We get a lot on this sort of pricing accuracy, and not just around risk adjustment, but the broader practices for how MA rates are set. So I am going to sort of slide over in that direction and ask you a couple of questions. I mean, at one level, and we've published a lot on this, at one level, I feel like we're sort of caught in an infinite loop. and we have a lot of infinite loops in health policy where many, again, there are outliers on all of this, but many people would say MA plans are probably paid too much, but they are also probably in the aggregate more efficient. Now, some of that efficiency comes from things that are annoying, like narrowing networks and prior authorization. But if you're going to save money, you got to do it some way. But then you get caught in this whole thing. Well, where does that money go? And you get all these extra benefits available to you if you're in an MA plan, but you may be subject to some marketing that isn't quite right. So I'm trying to think about, is there a way out of this sort of too much, too little, should grow, should shrink? And so I'm interested in your general reaction to that framing. Maybe I'll stop there because I have a few more specific questions.
Well, Alan, I think what you said points exactly to why we are looking at things like prior authorization and marketing in addition to the payment, because ultimately what you want is to pay accurately for the services that people need to drive the kind of innovation that's going to lead to higher quality care. And so that requires, number one, more transparency in what is happening in the Medicare Advantage program. So for example, now we're requiring medical loss ratio reporting for supplemental benefits, right? Okay, so there is money that's going towards supplemental benefits, and is that being utilized? Being able to lend more transparency so we can see what's working and what isn't. And also, how can we make sure that that money coming in is being used for care? Hence, looking at network adequacy. We recently increased network adequacy requirements, particularly around behavioral health, so that licensed clinical psychologists and social workers have to be part of, MA networks. The prior authorization, where you have clear rules of the road of where medically necessary care must be allowed in Medicare Advantage, so that we can make sure that we're paying accurately, more accurately by the risk adjustment model, and that we're really driving those improvements in care and improvements in access. And so really thinking about that all together is very important.
So that all makes sense to me. And yet when you talk about updating from 2014 to 19, I think, boy, we're always looking in the rearview mirror. I get that. Is it time to think about MA rate setting sort of as a distinct phenomenon than fee-for-service, the using fee-for-service as the platform as it shrinks? I mean, what if it's a third of the program? What if it's clearly no longer representative of the population? Do you have a long-range thought about where we go with this?
I think these are all questions that all of us have to think about. And it's a combination of, statutory authority, where there are things in the Medicare law for Congress, and where there are things that we have administrative authority to do. I always like to remind everyone, Medicare is kind of a 3-part program, right? You have Medicare law at like the 50,000 foot level, which sets the general parameters, guidelines, where we then in the administration have the authority to be able to put out regulations at, say, the 25,000 foot level to really guide the program, to then where care takes life on the ground with providers and patients and others who are, caring, health plans that are caring for people. And so, the question that you're raising of how rates are determined in Medicare Advantage is a combination of what Medicare law says and where there are, administrative authorities and flexibilities. And absolutely, this is something that we want to continue to explore, where we have the authorities, and explore it with everybody involved. We have really had an open door policy to hear from health plans, from providers, from academics, from patient groups of what's working and what isn't, so that we can incorporate that information as we all figure out together what is the best path forward. And that's something we're very open to continuing to discuss.
Well, this may fall more in the value-based section of our discussion, but we don't need to have firm boundaries here. One question about sort of the ACO program and things of its ilk, but that's obviously a clear and well-defined and long-standing one, is the role of the patient or the enrollee, that in MA, you have this natural pathway of saying, if you come over here, there are certain things we can offer you. in supplemental benefits and the like. And when it comes to a lot of the other things we're doing, like ACOs, we don't assign you. You may not even know about how you're getting your care. We're certainly not giving you any incentive to participate in it as a patient. All the incentives are over on the provider side. So is there a way to think about, again, as you're talking, I always like when I talk to you, because you start with what are we hearing from the patients and the enrollees. Is there a way to think about, again, a continuum from sort of total unfettered access to anything you want, but the costs associated with that, over here maybe is MA, but there are structured options in the middle that a patient enrollee would say, yeah, I know where I am. I don't want to be over here, but I also don't want to be over here, and I want to get some of the benefits of that. Is that a viable path?
Yeah, I think this comes back to how do you make sure that people understand what their options are so they can choose what's best for them, right? Where in fee for service, you have, access to a full, network of providers, right? That you don't have that narrowing. On the Medicare Advantage side, where there are supplemental benefits, these are things that people have to weigh. And there are huge opportunities to improve how we're communicating and aligning across them. I like to joke that if you walk on the street and you ask a 67-year-old walking down the street, hey, what do you think about that value-based care program? They're not going to know what you're talking about, right? But instead, being able to talk about, if your healthcare provider is in an accountable care organization, what does it mean for you? It means that your doctors are talking to each other. You're less likely to have medical errors. You're less likely to have duplicate procedures. You could have somebody who maybe comes to your home and is able to see, like a community health worker, and to see what's going on in your community to help support your health. And that has been a concerted effort for us to be able to improve how we're describing these programs through the Medicare and You handbook, through the materials that accountable care organizations provide to their patients, and where there are opportunities for us to be able to better lay out, like, here are the various options you have. Because, as you know, one of our goals in value-based care is to have 100% of people in traditional Medicare in an accountable care relationship, where they are working with a healthcare provider who is being held accountable for the cost and quality of their care, and really taking that broader view than just okay, this person's coming into my office for 15 minutes with this ICD-10 code, with this E&M code, and then I call it a visit, right? And that means that you would have traditional Medicare in this kind of more holistic care arrangement. And we also want to drive Medicare Advantage to make sure they're having, those more holistic care arrangements. And that's an area that we are exploring as well. We had questions in our RFI about it. We had requests for comment in our, C&D rule of how do we encourage, more of those kinds of holistic relationships in Medicare Advantage as well. Because for us, it's about the Medicare program. So we really want to try to align across the programs as well.
I know this is a little deep in the weeds, but and I know you love health affairs, but I don't expect that you read every paper the moment it comes out. We did have a recent paper on the growth of DSNP lookalikes, and it is a sort of the combination of all of these subjects you've been talking about, that what we're seeing is that even as we're trying to promote integration of care for people who are dually eligible with Medicare and Medicaid, that there is a marketing opportunity for MA plans to not have to have all of the integration of a dual eligible special needs plan, a DSNP. They can offer all these fancy add-on benefits because of how MA rates are set. They don't have to do the coordination. The enrollee, and this gets back to what you were just talking about, the enrollee doesn't get the benefits of integration that we've built into these other models, but they think they're getting something, and they're getting something of value. They're getting these supplemental benefits. That's probably not the most important thing for someone who's dually eligible, who may have very complex medical and social needs. So this notion of trying to sort of pull together the elements of rate setting, marketing practices, enrollee knowledge, integration, accountability, it all comes to a head right in this one place. And I'd say in this one paper, we have evidence that it doesn't necessarily come together the way we would want it to guide people into what's probably the best product to meet their needs. So read the paper if you haven't.
Yes, I have read the paper. No,
Great.
and this is where, I will say, Alan, this is why it's so important for us to always be engaging and hearing what's going on the ground. Healthcare markets are dynamic, and we always have to keep our eyes and ears open to make sure that we can address any issues that come up, or where there are things that are going really well. How do we help to facilitate and further, scale and expand those things? And so, we will definitely be looking into this.
That's great. So I'm getting a bunch of questions in from the audience. I love to bring those in. I'm going to do one now, and again, the boundaries between this topic and value-based are thin. But as someone like me who's worked most heavily on the Medicaid side, I feel like there's a very robust discussion about meeting social needs for the Medicaid population, lots of models around it, lots of discussion about it. Obviously, it's a lower income population, more likely to have unmet housing, food security, other kinds of needs. Medicare population has many people with those needs, but also some who are, of course, because it's not income tested, it's not as concentrated. How do you think about sort of you're within CMS, which has, the Medicaid folks having those conversations. Are you having those same conversations on the Medicare side? And what do they look like?
Oh, absolutely. And I'll take this from two angles. First, just organizationally speaking, it has been very important to all of us to work across our centers. So, partnering, Medicare partnering with Medicaid and CHIP, where they might have some best practices that could be helpful for us. Partnering with the Innovation Center, where the Innovation Center can be the R&D arm for Medicare and Medicaid, where the Innovation Center can test a model, and if it works, we can think about scaling it in the Medicare program. And even as we published in Health Affairs yesterday, I think, where we can use the Medicare Shared Savings Program as a chassis for the Innovation Center to test, to enable, more easy scaling if something works. So organizationally, those conversations are constantly ongoing. And I think policy-wise, we are definitely driving hard in that direction, really to think about care differently than that traditional fee-for-service way of providing care, and to incorporate it into the fee-for-service foundation. So for example, in the physician fee schedule that we just put out, we're proposing to pay for community health integration services. The first time ever that Medicare dollars can be used for community health services. And we tie it, as an incident to a billable provider and provide frameworks of they have to have a risk assessment, social needs risk assessment, which by the way, also we are proposing to pay for. But, being able to bring that into the foundational aspects of the Medicare program, I think helps build the muscle memory and the ability for healthcare providers to form these teams, build these teams, to enable them to then move into alternative, care models like an accountable care organization, principal illness navigation. We're also proposing to pay for care navigation for people with serious illness. So absolutely, we are taking some of what has been, shown to work in other settings and bringing, more into the Medicare program. And it's with an eye towards how do we move towards a more population health focus, where again, we want to have everybody in an accountable care relationship by 2030. That means from the ground up. That doesn't just mean those people who are in, an innovation center, model. It means also how are we driving the very chassis of our program to change the way that we're thinking about healthcare so that you really are addressing people's needs where they are, keeping them healthy, preventing them from getting sick so that you're spending the healthcare dollar in a smarter way and improving outcomes.
And this is where your opening comment really comes to play, which is that what Medicare does ripples through the entire system. So as you lead in this area, we know that there's a lot else following close behind. Well, look, we're gonna continue on these topics a lot, but I do want to bring up the second, at least, which also, of course, we could have an entire conversation about, but that's prescription drugs. Let's start with the provisions of the IRA having to do with drug negotiation. Those, of course, very much top of mind in the news. Tell us a little bit about how you think it's going right now, and I'm sure, as usual, I'll follow on with some questions.
Yeah, absolutely. I will say it follows along the same theme of what we've been talking about with Medicare Advantage and, all the value-based care work. Really, my goal is to drive better care, to have smarter spending of the Medicare dollar, to address issues of equity, to improve quality. And that is the foundation of the negotiation process that we have put forward in our guidance. So number one, the foundation of drug negotiation, there are various factors that we have to consider that was laid out in the law. And what we have said in our draft guidance and then we finalized was that the clinical benefit of the drug will be that starting point for how to develop an initial offer for the negotiation. Really thinking about what benefit a drug provides to people in comparison to a therapeutic alternative and enabling real world evidence to play a significant role, right? Because these are drugs that have been on market for 7 years or, 11 years, that you have the opportunity to have a broader appreciation and view of what impact this drug is having. So being able to, for example, consider if this drug is meeting an unmet need in the community. Does this drug have different impacts for different types of populations so that we can really get to issues of disparities? Thinking about caregivers, if you have a drug that is easier to take, then does that impact, ability to take the medication and ultimate health impacts for someone? We're saying also that we're interested in hearing about workplace productivity, the importance of staying independent, not becoming institutionalized. Anywhere that there is rigorous evidence of the benefits of a drug, we absolutely want to be able to consider it, because ultimately, why are we all in healthcare? Why does innovation happen? Because we want to have innovations that are going to really drive changes in health. And then from there, we also want to consider things like, what's the cost of producing and distributing this drug? What kinds of federal financial support were provided? What's the R&D cost? And again, to incorporate those things as well as we are doing the negotiation. And I think a lot of this just really is in line with the vision for the Medicare program that we've been talking about. And then I mentioned transparency before with Medicare Advantage, and that applies here as well, where we want to be able to get data evidence from everyone. And we're setting up a process whereby there will be patient-focused listening sessions, manufacturer meetings, and then once we send the initial offer, the manufacturer has the ability to do a counter offer. And then if there isn't agreement, then we set up to 3 meetings to have an organic back and forth negotiation process where ultimately then we will put forward publicly, what were the factors that went into play? What was some of the back and forth, again, to encourage that transparency that's also helpful for the healthcare market.
So part of the process is this maximum fair price. And when you talk about transparency, are we going to have transparency into what goes into that? Or is that part of the negotiation that's behind doors and is only revealed at the end?
So we put out in our revised guidance how we want to consider, these different factors when we are, coming up with an initial offer and moving through the negotiation process. But, we are maintaining the flexibility because every drug is different, right? Every drug is different. Patient circumstances are different. And we want to be able to embrace that nuance when we are doing negotiations with manufacturers. What we laid out in the guidance, and this was incorporating feedback that we got moving from the draft guidance to the final, because as you commented, Alan, one of the first things I always say is it's important for us to be engaging and hearing from people. And we heard, hey, we would like more transparency. So our CMS says we will do this negotiation process, and then publish, at the end. However, at any point along the way, a manufacturer can make something public and talk about what's happening in the negotiation. And if they do so, then we can as well. And if they disclose proprietary information publicly, then that means we can now disclose that, proprietary information. So that's kind of how we laid out, because obviously there's a balance, right? That transparency, but also respecting proprietary information and confidentiality.
Someone who knows a lot more about drug pricing than I do, which is a good number of people, raised to me this issue early on that as you, of course, start with a limited number of drugs, but as the role of negotiation increases, the dynamics of pricing change dramatically because there's now a negotiated price instead of these individual PBM negotiated prices, both for the drugs that are covered, but also for the ones that aren't part of the negotiation. How should we think about the interplay between Part D pricing and CMS's processes of negotiation and how those two together are going to affect what people actually are paying in the end?
Yeah, that's an excellent question. I will say that the guidance that we put out is for the first year of the negotiation program. So it is for the round of negotiation that is coming up where the prices apply for the year 2026. And that is because, number one, there are other provisions in the Inflation Reduction Act that don't apply in the initial year, for example, renegotiation. So we did not address those right now because we certainly have timelines that we are trying to meet right now. And also, to some of what we've been talking about, the healthcare market is dynamic. And I think we all need to learn and work together and see how things develop so that we can adjust our policies accordingly. So that's kind of one aspect that I think is important to remember, that this is for the first year. We asked, in our guidance for comment on that interplay between, formulary negotiations that the PBMs do in the Part D program and, our negotiation. And we incorporated that feedback into our revised guidance where we stated that it is our goal that there is meaningful access to these negotiated drugs. And we have processes in CMS based on the Medicare law where formularies cannot be discriminatory. They need to be grounded in clinical rationale. So if a Part D plan is going to put a negotiated drug on a non-preferred tier or have utilization management for that negotiated drug, we expect, a justification and an explanation of why that is being done. And that explanation should meet these criteria that we have in law as part of our normal formulary review process so that we can make sure that formularies are continuing to be non-discriminatory and to be clinically appropriate.
I just have to say, as an observer, it will be interesting to see the dynamics of the use of the word negotiation and how, after we've actually been through a round, or maybe it'll take two or three, I'm thinking of the new ACA marketplaces, of whether this is really price setting or whether there really is a negotiation. And of course, the talking points have been lined up for years on this, but it will be interesting to see whether in the end there is a robust negotiation, and then how people characterize what happened and whether they characterize it the same way depending on which side of the table they were sitting.
That is absolutely our goal, is to have a robust negotiation process. And that is what we have detailed out in the guidance that we put forward, to have this back and forth, and we talked with what happens right now, right? There's negotiation that happens in the commercial markets. There's negotiation that happens with DOD, with VA, with the Public Health Service, Indian Health Service. And we sought out ideas and suggestions and experiences from all of those areas in which negotiation happens today to help inform, how we're setting up this negotiation process.
Well, I know we'll come back to this topic every time we meet, but there are some other prescription drug issues that I want to make sure we talk about, not just the negotiation, although it's, of course, front and center right now. One is the coverage of these very high cost drugs for high prevalence diseases. So we have this in Alzheimer, we have it in weight loss. We've seen the effect of these new drug approvals on Medicare premiums. We've seen what seems to me and to some others to be sort of a sense that we're going to try to find a partial coverage option, the evidence development pathways to coverage with evidence, so that we're not just opening the floodgates, but we're also not saying we're denying care. Help me understand how you think. I know, again, I'll go back to your sort of the legal structure, the regulatory structure, the practice on the ground. Obviously, you have significant legal constraints with respect to how you treat drugs that have been approved by the FDA. But within those constraints, you have a number of different ways to go. And I wonder if you could say a little more about how you think, how you approach the high cost, high prevalence drugs, and also how you approach some of the expedited review, and whether that's a factor in how you consider your options.
So I'll start with the new drug law, because I think that those provisions definitely help with issues of affordability with drugs, and then I'll move to more on the coverage decisions and such. So I think it's important to remember that we talked about the negotiation aspect of the new drug law, but also the entire design of the Part D benefit is being redone, where number one, there will be an out-of-pocket cap for what people have to pay, $2,000 in 2025, which is huge. There's never been a limit to what someone could pay out of pocket in the Part D program. The $0 vaccines that's in place right now, the $35 insulin copay cap that's in place right now, and also the expansion of, the low income subsidy program to 150% of poverty. The Part D redesign also changes the dynamics between the plan, the manufacturer, and the government, which can be a whole separate deep dive into weeds of health econ, 201, which we don't need to get into. However, I think it just at a high level is important to remember that the dynamics of the entire market are going to change. And this is something that we will be examining, and that we hope to partner with others and hear what examinations and analyses they are doing in that space. But I think that Part D redesign is important to remember as we're talking about affordability of drugs and cost of drugs. And then the negotiation, where if there is a drug that has been on the market for 7 years or 11 years and qualifies as a drug that does not have, competition, and it rises in the gross expenditure for Medicare, it could be subject to negotiation, which also then, provides an opportunity to make sure that we're spending the Medicare dollar in a smart way. And the other aspect of the drug law is inflation rebates, where if a drug company raises prices faster than inflation, then they pay a rebate back to the Medicare program. That's another angle for addressing the high cost of drugs. So, we talk a lot about negotiation with IRA, but also the elements of the redesign of the Part D program and the inflation rebates can also have that effect on drug costs. Then moving to, some examples you gave, all the national coverage decisions that are done in the Medicare program do not consider cost. They are based on clinical efficacy and patient safety. And with the recent example of Alzheimer's, it really was around how do we make sure that we are getting the evidence that we need? I mean, ultimately, we all want to make sure, coming back to what we were talking about, where there's an opportunity to look at real world evidence, right? We want to make sure that we are continuing to get the best evidence so that we can continue to evaluate what's working, what isn't. And so hence having that registry, for the Alzheimer's drugs, so that you can continue to collect data that would be very helpful, given that, this is a very important population to be looking at. I think you might have also seen that the Innovation Center just announced a new care model for people with dementia as well. So, we're trying to address these aspects from multiple angles. And then, you mentioned the weight loss drugs. This comes back to, Medicare law and administrative authorities, because there is in the Medicare law, it says that Part D does not cover drugs for weight loss. Where these drugs are being used to treat diabetes, things like that, if there's another indication, that is something that, absolutely gets covered. And again, this is an area that we continue to partner with FDA and others, where it's very important that you continue to collect the evidence base about where different drugs are having an impact to determine where it makes sense for them to be utilized.
So I appreciate everything you said, and I'm thinking as I listen, you're absolutely right. We're fundamentally redesigning the Part D benefit, and it has to happen on both sides, and it does, but at different paces, which is not surprising. You described the patient out-of-pocket protections, which are, of course, huge from a patient perspective. From a taxpayer perspective, limiting the cost sharing just shifts the cost over to the taxpayer who has to pay. And then you've got things like the inflation provisions and the drug negotiation, but that doesn't get us, those two provisions don't solve the problem. They take a bite out of the corner of the problem starting in a few years from now. So it will be interesting to me, I guess I'll say, to watch whether the evolution on the trust fund protection side is as fast as the evolution on the patient side, because if we don't catch up on the payer, then we have a whole different set of problems, no matter how much we try to protect people through limiting their cost sharing. I guess that wasn't a question, but you're always welcome to react to. And I appreciate the clarification on the weight loss drugs. We know that from the law. But it also does sort of go back to this question of navigating between prevention and social, loosely called social needs and social determinants, and clinical medicine. And so much of the Medicare program, because of when it was enacted and its long history, is so focused on specific diagnosis. And so you can say, well, for diabetes, yes; for obesity, no. And that seems like we're going to have to start breaking down some of those barriers as well if we're going to prevent costs as well as just jump in at the end. Well, look, we've as I knew would happen, we've covered a lot in our time, but we're also I don't want the clock to run out until we turn to the third item you mentioned at the outset, which is the move to value-based payment. You've covered a number of dimensions of it already in the other topics, whether it's drugs or MA. But why don't we sort of start fresh there and tell our audience what your focus is, and we'll finish out our time going a little deeper in those topics.
Yeah. And I would say the same thing applies here as with, our conversation on the new drug law and on Medicare Advantage, where we want ultimately to advance equity, improve access to care, drive innovation for high quality care, and, have this be an area so that we can spend the Medicare dollar in a smarter way. And so it's really about transforming care. It's not just about these specific care models, while that is very important as well, but it really is about the whole continuum of what are we doing in the fee-for-service program, because ultimately what Medicare Part A and B cover, then Medicare Advantage covers, right? So what is Medicare Part A and B covering? Some of this we already talked about. The, proposing the community health integration, the care navigation, right? Also, we are making some of the most significant changes in behavioral health in the history of the Medicare program. We are proposing to create a new benefit, the intensive outpatient program. So currently in the Medicare program, you can have an acute inpatient hospitalization, psychiatric hospitalization. You can do a partial hospitalization, which is like a psych day hospital. And then the next rung is outpatient therapy. Now, instead, we're proposing a middle ground where you can have intensive outpatient programs. So that's a new benefit that we're proposing to create. We also are proposing, and again, this is thanks to congressional action giving us the authority to be able to do this, to have licensed marriage and family therapists, licensed mental health counselors, including addiction counselors, to become enrollable and billable providers in the Medicare program, which is huge in terms of expanding access to care. All of these things, moving towards this more team-based approach where you're getting more providers into Medicare, where you're creating new benefits. This is, again, part of transforming care in a way that can then hopefully enable providers to also be more successful in moving towards these alternative payment models. And we're really trying to drive growth in these alternative payment models. So the Medicare Shared Savings Program, which is under the Center for Medicare, is the largest accountable care organization program in the country. Right? We have more than 10 million people with Medicare in this program. And we have made changes to the program, again, in response to feedback that we have gotten and information that we've gotten from those who are living and breathing this program. We've made changes to the financial benchmark so that we can encourage more people to come in and encourage them to stay in the program. And we just proposed changes to attribution as well. Because again, as we are moving towards a more team-based and holistic approach to care, if someone sees a nurse practitioner or a physician assistant as their primary care provider, that should count for determining if that person is a member of that accountable care organization. So we've, proposed changes like that to further encourage, participation in these programs, because we really want to grow the providers and the people who are in these programs. We also launched this advanced investment payment program, taking something that worked in the Innovation Center. It was a model they tested, the ACO investment model, where they provided upfront investment dollars to providers so they could invest in the infrastructure that they need to participate in an accountable care organization. Well, that model worked, so we're scaling it in the Medicare program. So now small providers in rural and underserved areas can get upfront money that they can use to invest in teams, to contract with a community-based organization to address social needs of their patients so that they can become an accountable care organization. So we are taking various policy levers to be able to grow the participation in these value-based care arrangements as well. And it's all, again, with an eye towards driving that vision that we've been talking about. Because I really think that these holistic care models, and I say this from personal experience because I was leading care transformation at a health system before. I mean, it's incredible when you can have a community health worker who is going to someone's house and actually seeing what's happening on the ground. And, maybe someone doesn't speak English and doesn't have family members to go and pick up a prescription for them, and how do we address those things that can really impact someone's health? And that's where these holistic care models have a lot of power to keep people healthy. And ultimately, you're spending the dollar in the smarter way.
Well, I was just about to ask you, and then you beat me to it, because we've talked a lot at the 30,000, I think you said 50, the 50,000 and 20,000 foot level. We haven't talked as much, and that's where you come from, and that's where you have a lot of connections. So I want to ask, the first time we had this, I finished with questions about your career and the like. I won't ask you to repeat those, but I do think it's very important, as much as we talk about policy and theory and all of this and programs, all the stuff that I love and you do too, that we also remind people that you came into this job as a clinician and as in charge of transformation for a system. And so my questions are to try to sort of pull some of what you've been talking about down into that, or I should say maybe build a bridge between those. So, I've been doing what I do for a while, and I often had the sense pre-COVID that we were asking a lot of the healthcare system to transform itself, to rethink what its goals were, to rethink how it relates to patients. And we had electronic health records, and that was, going to change sort of the focus. It's not the 15-minute visit. It's the health of the population. And there was some enthusiasm, there was some resistance, but certainly those who were enthusiastic, and that's the world you were in, were like, here's some new tools and let's get into this. But it's hard work, it's exhausting, it takes a lot of resources. Then we go into COVID, and COVID is exhausting and everyone's working hard and it takes a lot of resources. It takes a lot of energy in the health system. And now, as the burden of COVID on the health system per se is abating, we still have a lot of residual effects in the system, burnout, cost pressures, and, just again, some exhaustion. And so this is sort of again, I'm asking you to sort of both step back and lean way in. When you're out there talking to folks who are in the jobs you were in, is it, we've been working at this so long and we're tired and we need a break, and you keep asking us to do more and to change what we're doing, and can you please just let us go to work for a 6 months or a year without having some bold new agenda? Or is it, okay, we were making great progress. COVID came along, it threw us off our game. Now that we feel those pressures aren't there as great on us, we're eager to get back in it and we're ready to go. What do you hear?
Well, I actually think it's a third thing.
Good,
which
even
is
better.
That the pandemic really exposed all of the ways that our healthcare system has been broken. And it's, things that a lot of us knew working in healthcare, but it really was brought to the forefront. And so where there is burnout, where there are, people saying, I want to be able to take care of my patients, and I feel like I'm not able to in the current environment, where there's that opportunity for us to be able to support that. And very much, one of the best parts of my job is being able to travel and visit clinics and visit people and talk with them. And I ask them, what can I do to help you? Right? What can we do to enable you to take care of people the way you want to take care of people? We all have those collective goals. And so I think that's where, a lot of the things that I've been talking about community health workers and, increasing access to behavioral health providers, those are all steps to alleviate the burden on one person, right? By enabling a community to really care for people. B, that tends to be more effective, as we know, which can also help with that sense of agency that you can actually do something to help people, which is why, a lot of us go into healthcare in the first place. So I actually think that it has presented an opportunity, and it is very important to me that we do keep in mind how policies can actually play out on the ground. So engaging people as we're developing policies to say, hey, what's working and what could work and what won't work, so that we're incorporating those on the ground perspectives as we're developing the policies. But then once we finalize a payment rule, it's important how that comes to life on the ground. So being able to, for example, with value-based care, really leveraging the ACO learning network so people can learn from each other, helping to forge connections between public health departments and providers, or community-based organizations and traditional healthcare providers, so that the goal is not just to put out a policy. The goal is to actually, have care happen, and having that partnership on the ground is critical to that.
So I think I'm going to squeeze one more question in before we close. I really hear everything you're saying, and it's funny. Someone just sent a question in right at the end that's a little different than my own, but I'll try to weave the two together. I love the passion you bring, and I'm sure you bring out that passion in the people you come and visit, or you go and visit, and you hear it from them. And I have no doubt that it's genuine. My work in this area has led me to believe that there are actually a lot of people who aren't ready for this transition, who aren't as enthusiastic, who haven't been trained in team-based care, who are who view us as loading more and more onto the primary care clinicians who are sort of the linchpin of some of the things you describe. And so that I don't want to lose that part of it too. So I guess the question is, I get it that if you're enthusiastic and you see this as the pandemic is opening your eyes to how much better we need to do, and you feel like you can be part of a learning system and all of that, and that's very motivating. But I know there are folks out there who don't have the same energy and passion for this as you do. And they're also, they're clinicians and they're doing their job and they're doing their best. How do we support them as well as we support those who are already sort of at the front of the pack?
Well, I'm glad that you raised that question, because it comes back to something we were talking about, that it's not just about people who are at the forefront in these, advanced models. It's about what are we doing with the everyday and the day-to-day. And that's why some of the changes that we're proposing in the physician fee schedule are important. Like you mentioned, primary care, we're proposing an add-on payment to acknowledge and value the complexity that's associated with longitudinal primary care. So really, on the ground, in the very foundation of the program, trying to provide those supports where we can. Where with GME, we're rolling out 200 new GME slots a year and focusing on rural and underserved areas so that you can get more people training in the areas that need them. Because you're right, believe me, I know it is not all, roses and rainbows and unicorns, right? And so we have to address things along the entire continuum however we can. And also, it's not solely the Medicare program, right? Like we are partnering with HRSA, for example, with workforce grants that they have, with Administration for Community Living, with their area agencies on aging, to make sure that, supports are being provided and having good, outreach. It is a combination of many things together that will help to, support people on the ground, caregivers, patients, as we continue to tackle, some of these really complex issues. But always remembering that these are all people, right? I mean, when we talk about those more than 64 million people in the Medicare program, each one of those is a person, right? And also remembering that there are communities, families, caregivers, healthcare providers who are taking care of that person, who are also people, who are also in, that ecosystem. And what can we do within our power to be able to support everyone in that way?
Well, it's always a pleasure, and I'm sorry to see our hour is coming to an end, but it just means we'll do this again.
Yes.
For our audience, I just want to remind you, we have on August 22nd a journal club focused on a paper in our August issue on home visits with a registered nurse not affecting prenatal care use or pregnancy health among Medicaid enrollees. This is an insider event. Insider is a membership program that offers exclusive access to content beyond the journal, including events, newsletters, and various other activities. We hope you've enjoyed this program here. We'll have other events you won't want to miss. Sign up to receive reminders at healthaffairs.org. And at this point, I can say both. Thank you, Meena. Thank you, Dr. Seshamani, for being with me on our Policy Spotlight. And thank you for being my guest today on a Health Podyssey. And to our audience, if you're listening to us in one forum, we hope you'll come and hear what we have to say in the other. We have many ways to get our health policy information out to the audience. But Meena, thank you for your service to the country and for being my guest. It's been a pleasure to spend the hour with you.
Thank you again for having me, Alan.
Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about a Health Podyssey.